Hi everyone, today we're going to be discussing about hyperaldosteronism. So hyperaldosteronism is a condition where your body is producing too much aldosterone. So this aldosterone is secreted by the adrenal cortex, which sits right on top of your kidneys. Now, aldosterone has two main jobs. Number one, it retains sodium, and number two, it excretes or removes potassium and hydrogen ions. So when aldosterone goes overdrive, you end up with this classic hallmark of this disease: hypertension with hypokalemic alkalosis, high blood pressure, low potassium, and high pH. There are two types of this condition. Let's start with primary hyperaldosteronism, also known as Cone syndrome. The most common cause of primary aldosteronism, or PA, is a single small adrenocortical adenoma, a benign tumor on the adrenal gland. Sometimes it involves bilateral adrenal hyperplasia, meaning both glands are enlarged. Who gets it? It affects females more often, typically between ages 30 and 50. There's also genetic link in some patients, and PA accounts for up to 2% of all hypertension cases. The second type is secondary hyperaldosteronism. Secondary hyperaldosteronism is different because the problem isn't the adrenal gland itself. Instead, something outside the adrenal gland is triggering excess aldosterone. Common culprits include renal artery stenosis, renin-secreting tumors, and chronic kidney disease. Let's talk about the clinical manifestations. Because of increased aldosterone, the patient retains sodium and develops hypertension and hypernatremia, which can also lead to headache. Even though the patient retains sodium, the patient does not usually get edema because the body compensates by increasing the rate of sodium excretion to prevent severe fluid overload. Because of increased potassium excretion, the patient develops hypokalemia, which causes general muscle weakness, fatigue, dysrhythmias, and glucose intolerance. Due to increased excretion of hydrogen ions, the patient develops metabolic alkalosis, which causes muscle cramps or tetany, tingling, numbness, and general weakness. So when you should suspect hyperaldosteronism? So think about whenever you have a hypertensive patient with hypokalemia who is not on diuretics. For diagnostic tests, the classic lab picture in primary hyperaldosteronism is increased sodium and decreased serum potassium. For imaging, a CT scan or MRI can detect an adenoma. If no tumor is found, we can measure 18-hydroxycorticosterone after overnight bed rest. A level greater than 50 nanograms per deciliter points toward an adenoma. Now let's talk about the nursing management. The preferred treatment for PA is surgery, specifically an adrenalectomy, which is the removal of the adenoma. This is most often done laparoscopically, so recovery is quicker. But before surgery, the patient needs to be stabilized. First, the patient needs to take potassium-sparing diuretics like spironolactone to block aldosterone from binding to the mineralocorticoid receptor in the distal tubules and collecting ducts. Second, give antihypertensive agents like calcium channel blockers to get their BP under control. If your patient's serum potassium is low, we can supplement them with potassium PO or IV. However, do not start potassium supplement and potassium-sparing diuretics at the same time. That's a recipe for hyperkalemia. Start one, stabilize, then reassess. Your patient also needs to be on a sodium restriction diet because they are already retaining too much sodium in their blood. Alright, and that's it. And this is going to be part of your next exam.